passively externally rotate the uninvolved arm. I always do the uninvolved arm first. And they go to here, and this arm goes to here, which none of you all are likely to have adhesive capsulitis. And they're like, oh, I do this, I get here, and I'm like, here, I'm passively, I'm like, oh, and they hurt all around their shoulder joint. That tells me something about the joint capsule. If this hurts, and it hurts when I'm pulling in, that's a muscle issue, right? Musculotendinous is active and passive in opposite directions, right? So, ow, that hurts. Oh, I can go further, and I push down. Ow, that hurts more. Now I'm thinking muscle tenderness of my rotator cuff or something like that. So you have to do all three phases, active, passive, and resistive, to truly get into that last component. So once you do that, then you can confirm it with your special test.
Okay.
That making sense? So we did external rotation. You can bring them up here and do it here if you want it to be, if it's a higher level person, you could do the same motion. Just grab their elbow, lift them up, and then passively externally rotate them. Yeah. Now, do you have that same pinchy?
No, it's more like elbow now, but
Okay.
can have you throw something.
Do the other side? Yeah.
Though?
Yeah.
Did it pop? Yeah.
Yeah.
Label.
She might have a labral tear. Does that feel equal on both sides?
It feels tighter on this.
Yeah, that's
side.
what I was supposed
Oh,
to
really?
say.
What? I just got it.
Cool.
She said she just has to shoes.
Now for internal rotation, I will just help them bring it up their back. If I'm doing it sitting, I do this test lying down. So this is the test that I would
It's not painful.
I would to do true internal rotation, I would stabilize the scapula and do an internal rotation. Most of the exam is done upright. So you all can do this in your clinic. That to truly assess glenohumeral motion, we'll lay you down and test that here in a second. But most of the exam can be done upright as you're doing that. So I don't do as much passive internal rotation sitting or in an upright position. Okay? So that's active, that's passive, now we have resistive. Okay? So a little different as we go through this, I have specific muscle tests. So if you look back at your component, I have specific muscle tests. So you can see my interpretation right above the drawing of the external rotation test. So limited active range of motion could be musculotendinous, neurological issue due to muscle weakness, capsular tightness. So it could be anything, right? You all seeing that on the interpretation? It'd be right here.
Oh, thank you. Okay, yeah.
I can tell. So this is from just that active and passive component. So passive range of motion evaluates capsular. So when you're passively moving thing, you're going to stress the joint capsule. Now you might lengthen a sore muscle, right? But it should be on the lengthening. She hurt in the back when we shortened the posterior part, right? So that wouldn't make me think musculotendinous. And then resistive range of motion, which we haven't done yet, but we're getting ready to do, is truly testing the musculotendinous functions. But different than what we did with myotomes. So myotomes, we worked at optimal range. Here we're gonna work at in range or in a lengthened position. Because way back in physiology, you all had that little bell-shaped curve, and the muscle tends to move, or tends to be optimally activated somewhere in the middle. That's not 100% true for every muscle, but for most muscles, that's true. Cool. How we doing there, Catherine? Good? Helping?
Oh, yeah.
All right. So just trying to keep it as simple as I can,
Yeah.
organize about that. So I don't know what you have versus the book says, here's what you do for tendonitis. Well, what if I don't know if they don't have tendonitis?
Right.
So I'm trying to think about this like a clinician, peeling back the layers, right? So I've done active, I've done passive. Now we're going to do resistive. So there's three or four basic tests that really does a pretty good job. Almost never do you have a deltoid tendinopathy. you can get that after surgery and total joints and stuff. So what we're really looking here is to evaluate the rotator cuff. So there's 3 main muscles. The infraspinatus and the teres minor you can't really separate with clinical testing. You can see a picture of it and it's separate that way, but in real life you can't function that way. So we have 3 basic tests. We're going to look at subscapularis, we're going to look at supraspinatus, and we're going to look at infraspinatus teres minor together. Cool? So I've already sort of assessed, all of you all don't have a rotator cuff tear because you could all lift your arms up and externally and internally rotate. If a patient can't, that would be when you can use what they call a lag sign. So they talk about a horn blower or a lag sign. So if you have a patient that can't lift their arm or hold their arm in a position, that's when we do a place and hold. So you all do place and holds as part of your rehabilitation, right? So you put the arm or hand or fingers in a position and say activate and hold. You're trying to do what? Turn on the muscle.
Yep.
Exactly. So that's how we're doing with the lag test. Yeah, it gets a little cold. Yeah, I understand. You're fine. We might ask you to bring it back off, but for right now, that's perfect. Yeah, don't freeze. So you're the closest, so I'm going to do this. So you're going to fake like you don't have a good functioning rotator cuff. So this side, do this side. So lift your arms up. Okay. They probably would get about half that, right? If it was really, ow, that hurts. Oh, and they're cheating and shrugging and doing all this other stuff. So what I would do is simply lift their arm up and ask them to hold it there. Oh, it's going to hurt. I won't let it fall all the way. Hold it up. Now she holds it, so it's not torn. But if it go bloop, that's called a drop arm test. It doesn't matter if you do it in abduction. That's the classic way in abduction, that they'll do it in pure abduction for a complete rotator cuff tear of the supraspinatus.
Okay.
Right.
If you need my shoulders for anything so they can all see, I'm okay.
Okay. I was saving your arm.
Oh, I'm fine. I don't have any arm issues.
Drop arm.
Under
Got it.
supraspinatus,
Yep.
Got it.
Perfect. Yep. Okay. So now the classic manual muscle test. I'm going to just do them real quick on her. So I typically start with external rotation. I also tend to test them bilaterally at the same time on the ones I can. So I'm going to ask you to try to push your arms apart. So I usually am standing here, but for the video I'm going to stand off to the side. So I'm going to try to pull your arms together. Don't let me. And so she can generate a good amount of force as she's doing that position. Okay? Internally rotating that a little bit puts it closer to in range. So if they're a little weak and you want to stress it a little bit more, I bring them in, now push out. And if they can't generate very good force, that would suggest to me that that rotator cuff tendon is irritated or partially torn. You can't tell if it's a tendonitis, tendinopathy, partial tear. You don't really care because you're not going to change anything in your treatment in the clinical environment. Subscapularis is internal rotation. Now, all of you all are young. Older patients can't do this as well. Turn around. Put your hand behind your back. So then what we have them do is lift this away from their back. They'll want to use their triceps, so you have to watch that, and that's called a lift-off test. So hold, don't let me push you down. I lightly push it back toward her spine. If they try to drop here, they're trying to use their tricep. So you can take it away from your spine very easily. If I put a little tension on that, you start to feel that. That's a little hard to hold.
Yeah, it is.
I don't have to push very hard. So that's the classic test for the subscapularis. A lot of people can't get their hand behind their back. Stiff shoulder, painful. This is typically older folks, 50 and above. So hand on your belly, bring your elbow forward, so turn sideways so they can see that better on the video. Good. So this is called the belly press test. This is also a test for subscapularis. So now I'm gonna pull this forward. We'll change the video, and I'm at the wrist, not at the hand, so they can't cheat. What they'll want to do is what she's doing. She's dropping her elbow. If they do that, go on and go back like that, that's no longer testing the subscapularis. She's using her lats. So they've got to keep their elbow forward. Hold. Don't let me pull it away. And she can activate that. You want to get it stronger? Give them not this, this. This motion strengthens the subscapularis. Not this. That bullshit that they do with the rubber bands is a waste of time. Turn around. Can they you see it better that way? Good. So she's keeping her arm perfectly straight. The other cheat that they'll do is if you put your hand here, is they'll flex their wrist. So I avoid that by just using the wrist. You've seen that in patients, or you've saw that in a book. You saw that little cheat. So there's two cheats: wrist flexors, dropping the elbow. If that happens, that would suggest a subscapularis tear. If they can't hold their arm here straight as they do that, that would be an indication that their subscapularis is not working right. I'm going to have you all do that here. We'll do one more. The last one's pretty easy. Arms out. I usually do this in the scapular plane, so not abducted, but a little forward of that, where you like to be anyways, about 20 to 30 degrees forward. Some people do it empty can, some people do full can, right? So if you're pouring out your glass, that's called empty can. This is full can. This is more provocative and more painful, but the EMG activity level is no different. So whether I test it thumbs up or thumbs down just depends how big a jerk you want to be.
I'll do thumbs down.
Okay. So you're basically going to hold there, and I come up around the elbows. I'm usually at the elbows. Hold, don't let me pull you down. And I'm looking
That face. Zoom in on that face.
That'll leave.
You ready?
Yeah.
All right. A little weaker on this side.
I am getting PT right now, so
Oh, for your shoulder?
for my neck and shoulders.
Oh,
so.
okay. Sorry. I'm glad.
No, this is good. This is good.
Good. All right,
Everybody's
you
hurt.
all do those.